Hello, everyone. Thank you for coming. Welcome to NADO's 38th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments in the chat and questions in the Q&A. We hope you will take advantage of this opportunity to engage with our speakers and attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in our daily drawings. Now, let me turn the stage over to Charles Hawley, NADO's Director of Projects. Charles?
Hi, everyone.
Hello.
Wrong button. Thank you for joining us. It's been a great conference. I'm clearly having a lot of fun and trying to keep everything moving along. So I appreciate your patience. And welcome everyone to this session, Novel Approaches to Leverage Data and Address Data Gaps. I'm excited to hear everybody's presentations and to really briefly thank our organizers for this session, Evaren and Chris Krawczyk with the California Department of Healthcare Access and Information. Let me introduce to you your moderator, Evaren with the Oklahoma Department of Health. And I will go ahead and get off stage and let Evaren take over. Thanks, Evaren.
Okay, great. Thank you so much. First, I'd like to just thank you all for joining our session. I think we've got some great presentations for everyone. I'd also like to thank Norm and Charles. They put so much work into this entire conference, and I know that I greatly appreciate it. Lots of idea generating conversations taking place. As Charles said, my name is Evaren Page. I'm the Director of Science and IRB for the Oklahoma State Department of Health, and I also oversee our data governance area. I will be moderating our session today. I don't want to take too much time up, so I'm going to go ahead and jump right in to present our first presentation, Medical Spending Equity Across Massachusetts Communities, Linking Data to Enhance Insights. This presentation is by Shalom Sine and Charlotte Chung. Shalom and Charlotte are both analysts for the Center for Health Information and Analysis. If you'd like more information, please check out their bios. So with no further ado, I'll go ahead and let's start the next presentation.
Hello and welcome to this presentation on medical spending trends across Massachusetts communities, where I will talk a little bit about the data sources that we were able to link together to enhance the insights that were available on this topic. My name is Shalom Sine, and I'm a senior analyst at HCAI, and I'm joined by my colleague Scarlett Chung, who is an analyst here as well. As a little bit of background on this project, we know that social determinants of health are linked with systemic barriers to accessing quality care. Our hypothesis was that these same barriers might have an impact not just on health outcomes, but also on health economics and medical spending as well. So we wanted to look at this further, and our objective was to contribute to HCAI's efforts overall to examine equity challenges in the Commonwealth's healthcare system by identifying differences in medical spending by community demographic indicators. So in order to address that hypothesis and address these research questions, we're looking at three main analytic areas, including medical spending, geography, and demographics. The research questions that we're interested in answering include: how does medical spending vary across Massachusetts communities? How do community demographics factor into the variations that we are seeing? And how do results vary across different markets and in healthcare services provided? This slide gives an overview of the methodology and the data sources that we were able to link together in order to apply an equity lens to our total medical expense data. And I'll break each of these main data sources down a little bit further in just a bit. In essence, the total medical expense data is collected annually by HCAI. It's an aggregate data submission that payers are required to submit to us and provides us with information about total medical expenses. We gather this data at the zip code level. So we're able to link it to the American Community Survey data. The American Community Survey is conducted annually as well. It's conducted by the Census Bureau, and it provides us with demographic information. So it allows us to apply that equity lens to the total medical expense data. The American Community Survey is available at the ZICTA level, ZICTA being zip code tabulation area. I'll talk a little bit about how we were able to crosswalk between zip codes and ZICTAs and the difference between the two. But ultimately, because the American Community Survey is available at the ZICTA level and the TME data is available at the zip code level, we were able to link these together and apply this equity focus to our medical expense data that we were already collecting here at HCAI. So to break these data sources down a little bit more, TME data is an aggregate data submission. We collect this data at HCAI on an annual basis, and it's required for all Massachusetts payers to submit this total expense information for both their fully insured and self-insured populations. We gather this data from all commercial payers and all payers of commercially administered Mass Health, MCO, and ACOA, and Medicare Advantage plans. Data submissions are aggregated again at the zip code level. And in this data set, we are able to see, among other variables, membership, which is reported to us in member months, and expenses, which comes to us as total medical expenses, but also is broken down into service category. So some of our service categories, examples might be hospital inpatient, hospital outpatient. We also have pharmacy, we have professional physician, and we also have telehealth this year as well, which is exciting. So we were able to link that data to the American Community Survey. The American Community Survey is an annual survey conducted by the Census Bureau. They survey 3.5 million households nationally, and 38,000 of those responses came from Massachusetts. They release their estimates annually with their data describing community characteristics down to the ZICTA level. Their margins of error are typically estimated to be under 1%. Because we are using the American Community Survey, we are able to see, among other demographic variables, but just as a few examples, race, ethnicity, education, language, and median income data describing the ZICTA communities through the American Community Survey data that's available to us. So I wanted to go over a few of the key lessons learned that we took away when we were linking these two data sets together. One of our key findings was that a zip code is not necessarily the same thing as a zip code tabulation area. So we learned that zip codes were designed by the Postal Service and are a collection of mail routes and delivery points, whereas a ZICTA was designed by the Census Bureau to describe zip codes as areas of land. So ZICTAs were designed with zip codes in mind, and in many cases there is a one-to-one relationship between them, but a ZICTA will describe an area of land, whereas a zip code won't necessarily describe an area of land and more of a route or a point. So fortunately in Massachusetts, we found that either there's a one-to-one relationship between the zip code and the ZICTA, and that was the case for most of the Massachusetts zip codes. In some cases, there was a many-to-one relationship between zip code and ZICTA, so we were able to, in those cases, have a crosswalk that allowed us to roll those zip codes up into a ZICTA. And in this way, we were able to crosswalk between zip code and ZICTA, and that was our bridge between the TME data and the American Community Survey data. Another key takeaway from this project was really the difference that I found between working with publicly available data and working with total medical expense data. Total medical expense data is collected by HCAI, and we have a lot of control over the data specifications and even the submission template. We designed the template that payers are required to submit data to us on. So we at HCAI are already very familiar with what's included in the TME submission, what is defined by each of our variables that we're looking at inside TME. But when we're looking at publicly available data, we need to be more careful about what exactly is included in each of the metrics that's reported, in order to make sure that we were being appropriate and responsible about the way that we are reporting out this data and linking it to our data. So one example would be the concept of a universe. So the American Community Survey publishes their data on data.census.gov, but each of these tables has a different universe, which is the Census Bureau's word for population definition. As a result of this, tables can't be combined, and we also need to make sure that we are aware when we're looking at at data that comes from these tables, what is the specific definition of what we are looking at, especially when we are trying to derive fields from this or calculate further. And our understanding of each universe depends on what is available in this publicly available methodology documentation. So as just one example, if we were to try and find the percentage of the population in ZICTA 1, 2, 3, 4, 5 who are unemployed, normally we would just take the number of unemployed over the total population and we would be able to arrive at a percent unemployed. But since we're working with a publicly available data set, we need to be really careful about what is included in that numerator and how the ACS arrived at that number of unemployed, and make sure that we understand that definition, and then also understand the definition of the total population or the universe that that table comes in. So in this case, we would be looking at the estimate of total non-civilian, non-institutionalized population in that ZICTA. So we need to make sure that we're understanding both the numerator and the denominator, and what the ACS's definition of the term total population might mean. I wanted to give a high-level overview of just some very preliminary findings, just to give an idea of the type of information that we're hoping to come away from this project with. So some examples of, again, preliminary findings, and these all come from the commercial market. We're looking at 2021 data. We found that higher median income in a ZICTA correlates with increased telehealth spending, increased total medical expense spending, and increased spending in a couple other service categories as well. And we're also seeing that ZICTAs with higher proportions of Black or African American residents correlate with decreased spending, both as in the total medical expense sense, and also broken down into some of the service categories that you'll see here. So again, these findings are just very preliminary, but it will give you an idea of the types of disparities that we're already seeing when we look at the data, the spending data through this equity lens. We're hoping to publish this report sometime in the fall or winter. So keep an eye on chiamass.gov for our upcoming publication. If you have any questions, please feel free to ask my colleague, Scarlett. And if you have any additional questions after this call, please feel free to reach out to me. I'm always happy to talk someone's ear off about this project. So thank you again for joining.
Evaren, you're muted.
Sorry about that. I just want to say, I think at the beginning I accidentally said Charlotte instead of Scarlett, so I apologize for that, but want to make sure I get it right. Thank you so much for being with us today to answer any questions. For those in the audience, if you have questions, please put them in the chat. I did have a couple questions myself. I was curious, I know that it's preliminary findings, so we don't get the whole picture just yet, but I was just curious, were any of your preliminary findings surprising to you and the rest of the research team?
We're actually still going through and looking at all of the trends, because we have so many different service categories in our expenditures, and we've pulled a lot of demographic data from the ACS, so we're still going through that right now.
Great. Well, I look forward to seeing the full thing. I was also curious too, other than the zip code level, what other breakdowns are available within the aggregated submission files? For example, are there demographics or diagnostic groups?
I can provide you with the link to our data specification manual for the total medical expense data request. But other than the zip code level, we've also asked payers to submit their claims data at the physician group and provider group levels. We don't ask for the demographic information in the data set.
Good to know. Were there any unexpected issues with obtaining or preparing the data for this analysis?
Off the top of my head, I know it was definitely a learning curve trying to understand the difference between zip codes and ZICTAs and trying to determine the best ways to crosswalk those. Luckily, we have a team at HCAI that uses census data frequently and was able to provide a crosswalk to us.
Awesome. Is there, oh, it looks like, is there a comment? So excited to see the final report. Have you run into similar quandaries of ZICTA versus zip code data? And that was summed up really well. So I think maybe similar projects involving ZICTAs versus the zip code data.
Sorry, I think my internet cut out. Could you repeat the question?
Sure. It said, have you run into similar quandaries of ZICTA versus zip code data? Yes, that's the question.
This is the first time that my team has worked with zip codes and ZICTA data. So yeah, that's what we're going through right now.
Great. Other questions from the audience? Oh, sorry. My bad. That was technically a comment, not a question. Anything else? Otherwise, we can introduce the next presentation. Okay, so our next presentation is, one second, is mobile gaming for healthcare data, appending and collection. So this presentation is from Bill Balderas and Scott Given. Bill is the president and founder of Futurity, and Scott Given is the co-founder of Motive Health. I hope I pronounced those correctly. So Charles, if you can go ahead and key up the presentation, we'll get that started.
Good afternoon, Otto. Thank you so much for having us today. I'm Bill Balderas, president and founder of Futurity. I'll be joined today by the president and founder of Motive Health Studios, Scott Given. Today, we're going to talk about mobile gaming for healthcare. And what we have found through some of Scott's research is mobile gaming is a very, very effective way to collect healthcare data, to append that data, to collect that data, and then to take actions and draw insights from that data. Scott, take it away.
Thank you, Bill. Let's just kind of dive right in. So what's the pain point that healthcare is facing? Collecting healthcare consumer data is just basically non-existent. Why? People just don't have interest in interacting with healthcare digitally, or more simply put, healthcare is boring and it's not inherently what people want to do with their time. Because of this lack of interest and just the reactive nature of healthcare, there's minimal to no utilization from a consumer standpoint with healthcare. Less than 1% of all time spent on smartphones and various apps, web browsers is spent with healthcare in any form, whether it's portals, websites, applications, disease programs, all of the above, which leaves almost no healthcare-based consumer data. And the impact of this is massive. So there's inconsistent data across the board. Intermittent and self-reported data contribute to this low utilization, care gap issues, and health disparities across the board, as healthcare doesn't have a great visibility into exactly what it is that they're trying to solve for. So a minimal view of consumer habits and economic data that influences utilization costs and the outcomes, and then high level of wasted expense because of the various forms in which healthcare is looking to gain this insight, or the resources, tools that they're deploying in terms of trying to collect this. And then from a higher level, just unmet deliverables across the board. 85% of health plans don't deliver on the engagement and interaction data and performance indicators that are required for them to drive up their performance revenues. So claims data is just one small part of the overall story. What's needed is a solution that people proactively want to use that is also a natural conduit for ongoing interaction. This leads us to mobile games. So if you didn't know, mobile gaming is now the #1 form of entertainment in the world, and it's risen to an unprecedented level of popularity. They're quite literally played by every demographic stratum of society. By the end of 2024, it's expected that over 80% of US smartphone users will be active mobile gamers, with the average time spent of 32% of all smartphone time is spent playing mobile games. And then from a demographic standpoint, everyone is playing. 60% of the active mobile gaming population are age 18 to 54. 16% of that population is over the age of 65, and the ages 55 to 64 represents the fastest growing demographic of mobile gamers. So quite literally within the next 15 to 20 years, your active population, the people that you're trying to interact with, will be mobile gamers. If you're not familiar, mobile games just repetitively facilitate interactions with ad-based content. This is how mobile games drive and generate revenue currently. So as a person, if you're a user, you have to interact with ads, content, information, pop-ups, all of the above in order to advance and earn in every game. You don't have a choice. It's the trade-off to play the games for free. So you play, you advance, you hit a certain place, and then you're delivered with ad-based content or information. Just last year alone, mobile games delivered over 100 billion impressions to US smartphone users simply through mobile games, which for us, we view as making mobile games perfectly designed for bi-directional interaction, unlocking a completely untapped channel to collect actionable consumer health data. So imagine if, as opposed to having to interact with ads, content, other information, or pop-ups, they're interacting with personalized healthcare information, high-value surveys, risk-based data instead. So mobile games are showing that they actually work. Driving engagement through mobile games have tangible results. This has been shown within the market. A recent program with a large Midwest health plan drove engagement, high levels of interaction, increased health literacy, and improved compliance across the board with a very limited number of introductory games and a low level of marketing just to see how natural adoption took place. The program increased preventative screenings by over 22%. That was almost 30% for people with diabetes. 91% of the population found using mobile games to interact with their healthcare was very easy to learn about and interact with, and it also increased health literacy by over 15%. On average, users interacted with almost 11 healthcare data points or content per day. Users completed over 5 health surveys per active user, and the monthly recurring utilization was what really stood out. 45% of the users of the program were monthly recurring users.
And the great thing about mobile gaming is it opens up this patient funnel, this patient journey that we've all spent a lot of time talking about. The challenge and the mistake we make with a lot of patient engagement programs is we limit access. We limit the very top of that funnel to a small audience, and then we wonder why we don't get the engagement and the empowerment and the outcomes. With mobile gaming, because they're played widely across age, race, income demographics, it opens up the top of that funnel to everybody. So suddenly we have like a much, much larger reach than we have with other forms of healthcare engagement. The second part is it's much more engaging than healthcare screenings and healthcare surveys that our patients are used to. They're built by people with degrees in psychology and cognitive awareness to make sure they become highly playable and people want to keep playing them. And to keep playing them, every few screens, they're interacting with healthcare content. So now you have people very willingly wanting to interact with healthcare content. The third part, and this is where a lot of programs start, we think about empowerment as the first step, but without that access and interaction, we don't get the empowerment. Once a patient is engaged with their healthcare content, now they can navigate and manage their health. And Scott showed the examples of the improvements within, things like screening and healthcare awareness. That happens only after we open up this funnel and get people engaged. And then finally are the outcomes. So because patients and individuals like to play these games for a long time, we get a nice big longitudinal data set, and we have visibility to that patient, to their profile, and we can improve the performance of the programs. So with that, that is why Scott and I really believe the time for mobile gaming is right now. There's an opportunity we've just never had before. The population has cell phones. The population is playing healthcare games. The population has access to high-speed internet. The current generation of our heaviest healthcare consumers grew up playing video games. And so what are the benefits for healthcare? Well, first, this is a better method for capturing consumer-generated healthcare data. It's more engaging and the access is bigger. And those two things alone make it a better method. It's an ongoing interaction where consumers want to interact. They're proactively giving this feedback instead of us trying to push, pull, and drag them to complete healthcare screening data. It gives us this much broader view, this holistic view of the patient experience, and that lets us better manage their outcomes. The way it facilitates the data delivery and the performance indicators to us, because that interaction is going, because that data is constantly streaming in, we will have a depth of patient analytics that we just don't have today. And finally, because this isn't one and done, because patients are always interacting. They're always in the interactive loop. It's a long-term engagement, and we get this longitudinal data related to these healthcare-related behaviors. Thank you so much, Nada. We really appreciate your time and attention today. As you can see from the research that Scott and his team at Motive Health Studios have done, mobile gaming is an incredibly impactful way to engage with our patients, to collect data, and to use that data to drive clinical outcomes. Scott and I really appreciate your time today. Our contact information will be on the screen. Please reach out to any of us, and we're also going to open up the floor for questions and answers now.
Excellent presentation. I think it really speaks to the novel that we put in the title for this session. I was curious, just to make sure I understand, are your groups, your companies building the games from the beginning, or is it more like a plugin that's taking the place in ads in other games?
Yeah, thanks, Evaren. That's a great question. So these are actually our games, right? Like they're mobile games that we have deployed within our own app store. But kind of what we've built is our health engagement engine that kind of like powers those health interactions. So right now, how typical mobile games work, there's effectively, they build the mobile game, and then there's kind of like a space that they leave open so that they can deliver ad-based content. And then from there, they partner with a mobile ad network to deliver the ads. They really don't know what's kind of going in and out. That's just how all games work. Effectively, what we've done, or what our health engagement engine is it's more or less just be simple like a mobile ad network, but as opposed to delivering ads, it's delivering personalized health content specific to the user, their demographics, chronic conditions, their health plan benefits, kind of all of the above.
Great. So how you mentioned it's part of your app store? Is it still available on like the Apple App Store? And how do people find and kind of engage with your products?
Yeah, so we partner with our primary client right now, our health plan. So we obviously, when we partner with our partners, there's a co-branded kind of partnership in terms of the outreach and communication. So in the same way they promote, diabetes program XYZ or this or any additional benefit, it's the same type of thing, right? But for us, we have some unique advantages in terms of kind of what like the style and look of our solution is. In that, right now, one of the issues is the solutions are static, and they're things that people just inherently don't have interest in. We have the ability to leverage the art assets from all of our games to be a little bit more targeted towards each user and the different demographics and types of games that those demographics like.
Great. So we have a couple questions in the chat from Bianca. How do you handle issues of consent in collecting this data? Which was one of my questions that I had as well. I think kind of piggybacking off of that, how do you ensure transparency and how users understand how their data is being used?
Well, so for us, we're high trust certified, HIPAA compliant through our partnerships with the health plans or the other organizations. Like, we need to have these in place. So we have our privacy policy terms of service. When a user signs up, they have to agree to our privacy policy and terms, which detail out all that information within there right up front before they're even allowed to create an account. So you can't create an account or move forward without kind of consenting to the terms of the data. And then in terms of the relationship with our health plan partners, that's just pretty typical with, a health plan or a healthcare organization and their, third-party vendors through BAAs and kind of like everything else. So there's like an implied consent with the vendor of the health plan in terms of, hey, this is a benefit that is safe. We believe in it. We want to offer it to you. And then we make sure that we're buttoned up in terms of all the other areas.
Sure. So can I ask just follow-up question? Because I picture those big, long user agreements that nobody actually reads, and you just click next because you want to get to the seen as a little bit, I guess, plainer language or more directed so that people really fully get that informed consent.
I'm sorry, would you be able to ask that again? I missed the second half of the question.
Sure. I'm just kind of wondering if it's like the big, long legal form when you sign up for something and people just click agree without reading it versus making sure that it's truly informed consent and delivered in a way that people know what they're signing on to. Right.
So when you click on the button, like, it pops up, and if you've seen the ones like where you have to scroll through,
and then like you kind of like does the check. I mean, we're limited in terms of the information that we can have, but also in terms of our outreach and marketing, we detail that information because that was honestly our biggest risk when we launched, was that people were just gonna be like, like this is too Big Brotherish, like I don't like it or whatever else, and it just simply wasn't the case. People really took to it and actually like enjoyed the content, and we candidly had issues keeping up with the content information that was being delivered because people were chewing through it so quickly because they just adopted the games as if they were typical mobile games.
Great. So from Elizabeth Davidson, can you give an example of what a mobile health game would be versus a health app like exercise programs?
Yeah, that's a great. Thanks for that, Elizabeth. So for us, like this is a game. These are mobile games. So think about, Angry Birds, Candy Crush, like these types of typical games. And that's kind of where healthcare, in our opinion, has been struggling because they're trying to offer like a health-based application that might have some gamified features. And that's just not what people want. So for us as the user, they have access to an entire suite of games. So different age ranges, populations, right? Like older populations prefer card and word-based games. Middle-aged women like kind of arcade and match threes and so on and so forth. All these different factors come into play. Our approach is more like a Netflix or Hulu, and that you have to provide option choice to cater to the interests of the user. So you could like, our Picnic Connect game, which is like a match three, kind of like a Candy Crush, whereas somebody else might like Solitaire or this Galaxy Defender game, or whatever else. So they're actual games, but as opposed to having to interact with ads at just an incredibly annoying frequency, at a much lesser frequency, you'll interact with content specific to, hey, did you know that you have XYZ health benefit available that can help you manage this and that, or, kind of questions about helping to complete HRAs and just your general health and specific to your conditions and all of the above. Does that make sense?
Makes sense to me. That sounds great. Another question from Elizabeth. So this service is a business associate of a covered HIPAA entity, which I think you mentioned that you were HIPAA compliant.
HIPAA compliant, high trust, and NIST certified.
Awesome. From Kevin, is the data shared by the vendor to others?
By us to others? No. So for us, like what's happening in the platform is our clients' data. Like we own the rights to kind of like the utilization, like interaction that's happening like within our cloud, but like all of the health-based data, if we're helping to complete HRAs, other types of surveys, the key learnings around the individualized health information, like that's our partners, and we're not sharing anything out to any other third-party vendors. No.
So when you mention your partners, for example, if the Oklahoma State Department of Health was interested in partnering with you, maybe we had a specific health, maybe diabetes or something like that we wanted to address in our community, we could partner with you. Is that something, like we develop content and then can get metrics back from the system, I guess?
Correct. Yeah. And so because in a lot of ways our health engagement engine too, like view it as it's a claims engine. Like we can intake raw claims and all this information to kind of bucket everything down. It's just how we deliver and have that bidirectional interaction is different. So for instance, right now we're in the process of basically going live with a large Medicaid enterprise. And one of their key goals is completing like health risk assessments and all these other high value risk, like just data that they need to obtain and interact with users around. That is effectively like impossible with how things are currently like being ran. So for us, we just deliver, like once the interactions are happening, we're delivering those data points in the format that they need back per their contracts to them, along with every other data. And same thing with, the state of Oklahoma. If we developed a program for diabetes, we'd set it all up, and then we would initiate the interactions and the data share, whether SFTP or API, to deliver back everything that you need with reporting around it.
Sounds really cool. Well, I think we need to move on to our next presentation. So for our next presentation is from Mike O'Neill and Peter Levin, the quandaries of healthcare data, viability, and governance. Mike O'Neill is the founder of Open Source Electronic Health Records Alliance and CEO of Medicasoft. Peter is the co-founder and CEO of Amida Technology Solutions. So if you're interested in their full bios, please check those out. And Charles, if you'll start the presentation, that would be great.
Peter and I will walk through some of the challenges and the opportunities for working with large amounts of healthcare data. I'd like to first start by setting the stage with our healthcare data environment, where we have an increasing set of data-driven use cases looking to improve healthcare outcomes, to improve efficiencies, to support research. All of these really drive a need for more data. And it's worth noting here, it's not just more data, it's more types of data from more sources, social determinants of health, community services, behavioral health, the whole range. If we were to think about an equation here, and the use cases are the demand side of our equation, on the supply side, we have some factors that are making data more available. That includes standards, where standards bodies have been evolving both how we model data, how we represent data, and how we exchange it over the years, and that's advanced from some of the longtime clinical and claims data standards that we're all familiar with, to newer things like HL7 FHIR, and increasingly standards for not just how we hold data, but how we share it and how we make it interoperable. On the government side, the regulatory environment has given us a push as an industry to make more data available electronically and to make it more interoperable. And the technology community has developed increasingly better ways for us to work with large amounts of data. That includes everything from cloud technology through data warehouse, data lake technology, big data analytics. So if we look at these factors, it sounds good. We have increasing demand, and it looks like supply should increase as well. But I would say that working with large amounts of data and new types of data, it brings its own set of challenges. First, there's just a complexity in dealing with so many different sources of data. As many of us in this community would go from claims data analytics, for example, to adding clinical EHR data, and then behavioral and community data. Much of this data, it's not yet part of the standards that we're used to working with. Some of this is sensitive data that requires special handling. And the more we get into data that lets us represent individual patients and their healthcare better, the more we have to factor in patient consent for our ability to use data or to share it. And naturally, we'll be required as a community to comply with legislation as things like the handling of reproductive data come up in legislative forums. Effectively dealing with these kind of challenges requires a structured approach. And I would say it's not just about the technology. I'd like to turn it over here to Peter to talk a bit about the approaches that we can take in this environment. Peter?
Thanks a lot, Mike. So I'm going to talk a little bit about how we administer the data. And what Mike has just described, I think really well, as usual, is the way that we think about the generative sources and the way that we consume the data. And guys like me, we think about the stuff in the middle. We think about the administration of the data. We think about the structure of the data. We think about making it available in a safe and secure and reliable way. So what we're depicting here is a very simple data governance overview. And you can see what we're trying to do is encourage the idea of these administrative overlays. So the bottom part of this picture, we're looking at retrieving the data, transforming it in some way, and consuming it, right? And in the top part, we're thinking about what are the ontologies that we're using? HL7 is a good example of that. How are we registering the data in a taxonomical classification, or a fancy way of saying catalog? So we are thinking, and we're advocating strongly, that we shouldn't just be looking at the downstream consuming applications. Super important. This is where guys like Mike live and breathe. We're a little bit upstream of that, making sure that the data that we're consuming is safe, it's verified, it's reliable, and we're keeping really good track of it. So kind of focusing a little bit more on the idea of this administrative overlay. Here's what we mean specifically. So we're talking about the information models, or the what. We're talking about the data catalogs, or the where. And there's some pretty clever ways now that, as Mike has mentioned, it's not really a technology problem anymore. It's really a governance problem in a lot of places. Who gets access to the data for what purpose? How are we keeping track of where they're going and what they're doing with it? occasionally some of the downstream consumers will create new data objects that we want to retain for future use. They're coming up with great ideas. We want to capture that in innovation, put it inside of the model, make sure we know where to retrieve it next time. So here's an example of that. And I'll close my part with this slide. And I just kind of wanted to set out a little bit of a teaser. This is a graph database, or a GDB, and I wanted to give the audience a little bit of a taste of where the industry is heading. The guys like us that are focused on the infrastructure, looking at the volumes of data, the velocity of data, making sure the veracity of the data. Here's an example of something that we have to be super careful of today that we weren't even thinking about 2 years ago. The data that is stored in the relational databases, which we know we're going to be using for training sets for AI and ML applications, personally advocating that, think it's a great idea, but we have to make sure that those training sets are unbiased, unskewed, non-prejudicial, non-discriminatory. So before we even start training those sets, we need to make sure that according to the mathematical frameworks and structures, and frankly, our societal expectations, how do we know that we're teaching these machines to do the right thing? One really good way to do that is to put the data into a graph database. I've taken a snapshot of one here on the left side. We actually made that one. It's for a different application, but it really applies here. We're taking these graph databases, we're normalizing the data independent of the upstream format and structure, putting it into the GDB, and then we're looking, in this case, we're looking for cyber vulnerabilities. But imagine, blur your eyes a little bit, that these colors talk about how is that data distributed according to demographic? How is that data distributed according to disease? How is that data distributed according to social determinants of health or health outcomes? So my part of the talk is to talk a little bit about the data administration, what we mean by information models and catalogs, and to tease the audience a little bit about alternative ways of presenting the data. And here we are showing a graph. Mike, back to you.
Great. Thanks, Peter. What I'd like to do is take a couple of minutes just to talk about a framework, or you could say a platform approach, that we might take to capture some of the technical and governance elements that Peter just described. And what we're after here is a way that lets us get started now, but gives us the flexibility to evolve as our data environment evolves. So one of the first steps that we would take in selecting a framework and an architecture like this is to choose a data model. You can see here at the kind of middle of this platform diagram, we're using HL7 Fire as the data model internally. Fire, it turns out that it has good flexibility to handle the types of data we deal with today and be extensible enough to support the types that we may need to support in the future. And it's also really constructed with interoperability in mind. Architecturally, and I know we're talking at a very high level here, but we can think in terms of three basic parts: a collection of services that we develop to deal with getting data in, various types of data from various sources, and bring it into the platform. And a clinical repository in the middle there that deals with longitudinal patient records. This is in service to your use cases that support treatment or care delivery. And the third part is a data warehouse that's optimized to support analytics workloads, AI, machine learning, the types of use cases that Peter touched on in his description. There are also some other things here that we can just mention briefly, capabilities to easily add things like a rules-based policy engine when we have to think about the complexity of controlling who gets to see the data and for what. And we have to factor in everything from patient consent to legislation. Maybe the last thing to say about the platform approach is it's not tied to any one particular technology, so it gives us flexibility enough to adapt as we deal with new types of data and as we deal with the scale as your data needs grow. The last thing that we'll say here is both Peter and I enjoy the theory and the strategy involved with healthcare data, but at heart, we're engineers who build systems that real people use. So a few things that we would advise: it can be tempting in a complex environment to wait until things settle. They never do. So getting started sooner rather than later is typically a good move. If you can make some architecture decisions that don't kind of lock you into data silos, but give you flexibility, and then take an iterative approach. There's nothing wrong with taking a first step followed by a second and so forth, and be guided by the stakeholders in your ecosystem who have real problems that will benefit from using your data today. If you make those kind of priorities as you make your investment decisions, you have a pretty good shot at getting a good return on those investments and being confident that you don't need to throw away an investment each time you tackle a new challenge. With that, we'll conclude our talk. Thank you.
Great, thank you so much. So we do have a couple questions already in the chat. For Mike, curious, so an organization can spend a lot of effort putting a data governance structure in place, but then find that control of their data still erodes over time. Are there ways to prevent that from happening?
Yes, I think that there are. I would pick up on the point, one of the points that we just ended up with there, that there's theory and strategy, and as I said, Peter and I are both proponents of those things, but we're engineers. So how does this relate to the question? To the extent that we let governance become its own thing that isn't tied to the real world implementation that you're using your data for, you can have this problem. You put a lot of effort into a structure. It is great. In theory, it's going to work great. But if it's not tied into your system and your processes, people don't follow it. And pretty soon your data ends up being out of governance. So, okay, all I think I've done there is restate the question. So there's a couple of things that we have collectively found is really effective. One is on your actually, I would say on your architecture. One of the things that can prevent people from applying good governance is difficulty in implementing it. If you, in order to meet some provenance guidelines or tracking or something like this of disparate data sources, and by the way, I have to say in our previous presentations, we've heard some really great examples of how and why and from where we get a lot of different types of data that can stress your governance infrastructure. In any case, if your architecture is flexible enough to handle metadata, to handle information about your data, to even model the types of data itself, it tends to help your governance flow. As soon as people find that implementing it is a problem, you tend to get workarounds that I'm not talking here about anything that's done with bad intent, only with very good intent to meet project deadlines and do useful things. People can start to work around the process. So an inflexible architecture is a problem. The other is to make sure your governance is tied into your development and particularly your change control processes. So if you want to make sure that some governance policies are followed when changes are made to your production data ecosystem, then those data change control processes have to include checkpoints for governance. It sounds obvious, but we found many times when people miss that the processes, the very processes they use to make changes to their production data ecosystem, don't factor in the processes in governance that they spend so much time on. So that linkage is really important.
It's a great suggestion. I think I definitely have seen that myself, where sometimes those checks are not getting, the engineers go and do something in the data environment and forget data governance even exists. So next question for Peter, can you further explain to us the difference between an information model and a data catalog? Why do organizations need both? Oh,
Peter, we're not hearing you.
Yep.
Steve, let's try it now.
Now we are.
Okay, sorry about that. Thanks for the question. So the classic example here is a library, right? Because libraries have catalogs, and that's kind of where people default. And the question is, how do you characterize the data that you have? And we would know how to map that if we were talking about health data. There are different formats, structures, attributes that we know very well and we understand completely. Where does the pharmacy data go? Where did the images data go? But let's talk about a generic case where you're really trying to characterize what you have. So let's go back to the library. So there are old books in our libraries today, and we don't know that we even have them, right? Because we've been accumulating them over many years. They're in the basement, they're in the attic, and they might be really useful to us. So that would be one reason why we want to be able to have an information model in addition to the catalog that we're creating. A second one are new books. How do you know where to store them? So if you're looking for data, if you're using an ordinary catalog, all you're going to see is what you know is there, but you're not going to see what you don't know is there. That's the first reason you need an information model. The second one is the new things that are coming in. How do you know how to properly characterize them? How do you know where to properly store them? Yet another reason for an information model. So the way that we think about things, you really do need both. You need the catalog, which is the where. You need the information models, which are the what, and that they work together seamlessly. And there are commercial tools that do that these days. Our observation is that most large systems, whether it's a payer system, a provider system, patient advocacy system, federal healthcare, they're really right now myopically focused, exclusively focused on the catalog, which is a great place to start, but it's only the place to start. It's not the place that you end.
Great. I do have one last question, and then we'll bring everybody back into the session. I was curious if you could speak to how you identify and obtain funding, as well as the staff capacity to kind of, develop these platforms that I think everybody can agree are great ideas, but how you get there, it's challenging sometimes.
Yeah, Peter, you probably have some comments as well. So let me answer first from kind of my domain, where we build these type of data platforms that handle many of the types of data we've talked about here: claims data, clinical data, adding other types. So the way that we look at it, and one of the recommendations that we made in our slides there was to take an iterative approach. So instead of saying, I need to go build the perfect platform, let's say, which used that way, platform quickly becomes a buzzword. And then I will go implement a health information exchange or an APCD or something. What we do is say, no, the priority is you need to implement a data warehouse for an APCD. As we do that, let's make choices that fit a platform strategy. So in things like selecting the data model, one that will be flexible over time, making sure to partition the services that ingest or manipulate your data from the services that aggregate it and make it available for treatment, versus the services and the data repository that makes data available for analytics. If you make good platform-oriented architecture decisions along the way, what you end up with is both a functioning system that's helping real people use the data, and one that has followed a good platform architecture approach. And so it will continue to support you as your needs evolve.
Great. Well, we only have about 8 minutes left in the session. We do have one more question in the chat, but Charles, if you can go ahead and bring everybody back on stage. If you have any lingering questions, please post those in the chat. While we're kind of waiting for other people to join, Helen had a follow-up question for Mike. When they say things like take a platform approach or make good architecture choices, that sounds easy, but in reality, how does it get done?
Yeah, I'd say it gets done in the way that I won't repeat the things that I just said, which is build a real system and make good choices as you do it. If you start to think about, I'm going to build a perfect architecture and then implement a system, often you'll get stuck in the things that are being mentioned here. So not to repeat, but starting with things like your data model, how you set up the different phases of your system. You have to build something that's real and do it in a context of an overall architecture.
Great. There was a question earlier from Elizabeth, which was for Scott and Bill, asking about what is the business model, and is it data monetization, or does that make sense?
Yeah, it does. So we contract directly with our partners. So, and that's kind of another thing too, in terms of like the consent component of this, is our games just aren't kind of like out there in the ethos and just hoping that, our health plan partners, like people happen to find it. So it's being offered and marketed directly to these individuals. And so we operate with a typical, whether it's like a PMPM type model or value-based performance, kind of all of the above. It's not a one-size-fits-all solution, in that, we're gaining interest from big pharma because they've got the same issues and they don't really operate with those types of models. They more so look at like licensing, but traditional kind of like healthcare models around like per member per month or value-based performance, a combination of both. Yeah.
Great. Got several comments in the chat. Everybody's loving the session today. I think we've just got about 5 minutes left, so maybe real quickly for each of you, what is one takeaway that you would like the audience to leave with today? One final thought for each. Scarlett, why don't we start with you since you were our first presenter today?
Sure. That's a great question. I think our goal and our hope that users take away from our report is that we are able to provide a neutral and factual basis for policy discussions, and we're hoping that readers of the report and stakeholders can use our report to provide them with avenues for different areas that they should focus their health policy on.
Great. Scott or Bill, what would you like the audience to take away today from your presentation?
Bill, do you want to go or you want me to go?
Sure, I'll jump in. I would just say even outside of mobile gaming, user-generated healthcare content is so important, it's so valuable, that first-party data, and it's really, really hard to get because consumers are flooded with all kinds of messages. So the more innovative and creative we are, the more we can meet consumers where they are instead of making them come to us, the more likely we are to get really valuable data.
Great. And Peter and Mike, one last thought from your presentation?
Mike, do you want to go first?
I will sound like I'm on repeat now, but I will say, go iterative, get started, build a real system, and make good architecture choices in that context.
So I would say that infrastructure is unglamorous and even boring, but we all get kind of grumpy and irritated if we turn on the light switch and the lights don't turn on. If we turn on our GPS and it takes it an extra 5 seconds to figure out where we are. So folks like me really focus on the infrastructure. The summary for me is if you get your data right, nothing else matters. And if you don't get your data right, nothing else matters. So get the data right.
Great. Well, I'm not seeing any other questions in the chat. So once again, I would just like to thank all of our presenters for being with us today. Great presentations all around. And again, thank you to Norm and Charles for all the hard work that they've put into organizing this conference. So I thank you all again and hope to collaborate in the future.
Perfect. Thank you.